Go ahead. Orator, you can start.
All right, so our presentation is on common mental health issues in primary care. I'm with Dumelo Mashatula and Charmaine Makaling. We're all together here. So the general aim of our presentation is to kind of give an overview of mental health in primary health care, the impact that it has on our community, the education level at our community, and how to manage it on a primary healthcare level. I think we haven't been exposed to psych because we started with family medicine. So it is kind of a tricky territory for us at the moment. But I think most of us have also been exposed to psych patients or mental health care users in the primary healthcare setting as well as at district level. So these are the questions that we asked ourselves around the presentation. I'm going to go through some of them, but some of them you can read. But the most important for us was how common are mental health issues in our community? How do we educate our patients regarding mental health? How do we destigmatize mental health in our community in the context of cultural awareness and such things? And in terms of management, what are the legal practices around mental health care? How do we familiarize ourselves with them? And on a consultation and family medicine level, how do we conduct a psychiatric interview? How does the referral generally work in primary health care to higher levels of care? So this was just a general information slide about Mental Health Awareness Month, how we can participate in increasing awareness. And an important thing in our context is cultural awareness as well. I think in terms of things like psychosis and we need to be more aware of the cultural implications of that, the cultural beliefs, especially at a primary healthcare level, which we'll go into a little bit later on. As alluded to by our colleagues before, the current law governing definitions in mental health, the rights of mental health care users and legal procedures and such is governed by the Mental Health Care Act of 2002. I think I just wanted to highlight the broad objectives of this act, and it serves to regulate mental health care in terms of making sure that the best possible mental health care and treatment and rehabilitation services are available in an efficient and equitable way in our community. It governs access to mental health care, procedures towards access to mental health care, and how to integrate mental health care into our general healthcare services. It also regulates how patients are admitted in terms of whether they're voluntary, assisted, involuntary. It also surrounds state patients, mentally ill prisoners. It also clarifies the rights of mental health care users as well as mental health care providers, along with our obligation. And it also regulates how the property of people with mental health care illnesses is handled by a court of law. So according to an article by the WHO specifically targeted at mental health care in a primary healthcare setting, the main objectives that they highlighted were, in a primary healthcare setting, it is important to empower and engage individuals in the community. And I think this alludes to what I've previously mentioned about educating patients about different types of mental health care issues, which we'll mention, and handling family members with such issues, cultural awareness, stigma around those kind of issues, overcoming the myths and prejudices and for reducing stigma, like I've mentioned, empowering and engaging people with mental disorders in key aspects of service planning and decision-making in terms of how to take care of themselves, how to support families that take care of such patients, things like community support groups and training community healthcare workers in terms of dealing with mental health. And the last one would be ensuring that primary care services are supported by specialist services in hospitals to take referrals and to down refer patients. I think for us as interns and as primary healthcare workers, this would be one of the things that stand out in terms of how to refer a patient within the clinic or CHC if there is a psych department, and how to refer them onto a district level and eventually a tertiary healthcare level or other psychiatric or designated psychiatric institutions. Then in terms of what are the common mental health issues that we see in primary healthcare, so this is based on things that we've seen both at a clinic level and at a district level. So the three of us have been at Beki, Len South, and Shawela. So we've taken time to see what are the more common mental health issues that we see. The number one that we've pointed out is substance-induced psychotic and mood disorders. We see other mood disorders, whether organic or substance-induced, psychotic disorders, behavioral problems associated with either substances or intellectual disability. And I think this is one not to be taken lightly because it requires a lot of support in terms of primary healthcare workers, community healthcare workers, and family and other allied specialities. Substance use disorders, and then the least common that we've seen were underlying personality disorder, whether diagnosed or not, or part of a dual diagnosis. Comorbid anxiety disorders also go very underdiagnosed. And then elderly associated psychiatric issues, so dementia, whether Alzheimer's, vascular dementia, things like that as well. Another thing that we noticed, the stats were very scanty, but we were able to kind of get the following, that the more common age groups were between 19 and 35. And we did see more common pattern in male more than female patients. We did see from interviewing patients, the more commonly used substances were marijuana, crystal meth, cat, and of course, nyaupe as well. And we did notice a pattern of these mental health issues being commonly associated with poor home environments and multiple surrounding psychosocial stresses. So primary mental health care in action means when you are encountering a new or known psychiatric patient in mental health care, what are the key things that we need to focus on? So I'll kind of give a brief summary on consultation in a clinic setting, or what they call the psychiatric interview, dealing with the family of a mental health care user, basic counseling and advice, referral when necessary to either district level or tertiary level in contact with the relevant specialists and in line with the administrative protocol. So that refers to your Mental Health Care Act forms. And just knowing a basic overview, I think is important for us as interns especially. So I'm just going to have a general overview of the psychiatric interview. I think it starts as your normal history of general demographics, which are important in psych, especially surrounding where the patient lives, who does the patient live with, supportive structures, schooling, highest level of education, home language, religion. I think the psychiatric interview goes much more into that because they do take much more of a biopsychosocial approach. And then the main complaint can either be from the patient themselves, family members. So I've had more commonly family members bringing patients with much more poor insight to tell us what is going on with the patient. Sometimes, as seen in a more district level, the main complaint does come from law enforcement. The person is brought in by the police or by the EMS. In terms of exploring the main complaints, there are certain clusters. This is just a generalized summary. They're much more broader clusters. But in terms of the mood structure, basically it's to seed out symptoms of depression, mania, or sometimes both, or sometimes, as will be explored by my colleague, somewhere in between that. So in general, we explore mood. The patient may describe feeling elevated, may describe feeling low, or may describe cycling between both. How is the patient sleeping? And sleep is also a whole different psychiatric field on its own, which we don't have the time to go into. Interest, so meaning anhedonia, because the DSM does mention low mood and anhedonia being one of the main criteria for depression, and the others as seen on the slide. In terms of mania, we do see this much more commonly, but it might be because it presents much more obviously in a primary healthcare setting, an ED setting. Patients may tend to describe racing thoughts, goal-directed behavior, risky behavior, grandiosity, and so on and so forth. And then the psychotic cluster mainly describes a feeling of detachment from reality. So a patient might describe hallucinations. It's very important to seed out these hallucinations. Are they visual? Are they auditory? Are they commanding hallucinations? Because this might help you assess whether a patient is a suicide risk, a homicide risk, and so on. Exploring delusions may also help to assess whether a patient is dangerous or not, how strong are their delusions, and then special powers and messages, which we see quite commonly. And then the other clusters include anxiety, cluster, and the trauma cluster. The trauma cluster deserves a special mention because it's especially relevant in our country. It's important to seed out histories of head injuries, histories of assault, of violence, because there might be a background reason for the presentation of the patient. Like I said, there are many more other clusters, but because of the restricted timeframes we face in this presentation and in the clinics, I will not be mentioning them now. And then that's the rest of the interview. In terms of, at the end of the interview, it's important to have a mental state exam. It's almost as if it's almost an assessment of the patient in very short terms, in terms that are understood by everyone. So the mnemonic that we found is a mnemonic called aseptic. So the A would stand for appearance and behavior. Is the patient well kept? Is the patient disheveled? Is the patient in hospital attire? Is the patient not? How is the patient behaving? Is the patient, do they have any psychomotor abnormalities? Is the patient restless? Is the patient drowsy or sedated? Speech, is there increased volume, pressured speech? Then emotion, mood, and affect are kind of what you get from the patient during the psychiatric interview. Do they have, are they euthymic? Are they elevated? Do they have a depressed mood? Are they dysphoric? So all of these terms are terms that you get to learn the more you see psych patients. Then the rest describes perception. Are they objectively hallucinating? Do they have delusions? How is their thought form and thought content? So thought form describes the relevancy. Is it logical? Are they tangential? Things like that that you, like I said, pick up in the psychiatric interview. And then lastly, which is also really important, is the insight and judgment of that patient. Are they aware of the diagnosis and what is their judgment in terms of things that they do? I think this is the most important slide before I hand over to my colleagues. In terms of how to refer a patient within PHC level to a psychiatric department, for example, what I've experienced at Shawela is that before referring to a psychiatric department, the exclusion of an organic cause for psychotic or mood symptoms, especially in an index presentation, is required prior to referral. So in order to do that, the psychiatrists require a thorough history, like I mentioned before, the psychiatric interview, an examination of the patient, an assessment, a biopsychosocial assessment to assess any stresses and underlying triggers, a thorough history from the family members, and then in terms of baseline bloods, to exclude any electrolyte imbalances, any hormonal imbalances that might be a cause for the psychiatric presentation, a multi-drug urine test. And then it's important, especially in the elderly, it's very unlikely that they'll present with a primary psychosis. It's very important to consider delirium and or possible sepsis or a source of sepsis as a reason for their presentation. So the important lesson is to learn that often the psychiatry department is more hesitant to accept the patient or may not accept the patient without the complete workup being done. And lastly, for me, this is the flow of the Mental Health Care Act forms. So the most important forms, so this is being done at a district level as well, is to sign a Form 4. So this is just for our level. Form 4 is a form that says the family member agrees to the patient being admitted for observation. So this form has to specifically be filled in by the family. If not, under strenuous circumstances, that's when you can fill it in as a healthcare worker. And then 2 healthcare professionals need to fill in a Form 5. So this form says that the patient can be admitted for a 72-hour assessment. So what I've seen is some people fill in a Form 4 on one day, then after 24 hours, they fill in the 2 Form 5s. Other healthcare professionals fill in the Form 4 and the Form 5 together. I haven't been able to ascertain which is the correct way to do it, but this is the way that I found. And then it has to go through strenuous processes of being approved by the mental health care board to accept the patient for, especially if the patient is involuntary. So the patient can be admitted voluntarily, involuntarily, or as an assisted admission. So I thought this slide would be helpful for people to keep on themselves to know, especially if you're going to be in an ED, of which forms need to be completed at which time. So I'm just going to hand over to my colleagues to just give you a brief overview of the more common mental health care disorders that we see in primary health care.
Okay, so I'm going to talk about psychotic disorders. As I've listed below, except for substance or medication-induced psychotic disorder, which is going to be covered next week. So as a general, these psychotic disorders can be summarized using the criterion A of schizophrenia, which says that 2 or more of the following must be present for a significant portion of the time. So perceptual disturbances such as hallucinations, thought process, disturbances such as delusions, disorganized speech, grossly disorganized or catatonic behavior, as well as negative symptoms. So in the case of a brief psychotic disorder, you'd have 1 of the positive symptoms of criterion A of schizophrenia for a duration of less than 1 month. In schizophrenia form disorder, you'd have criterion A between a duration of 1 to 6 months. In schizophrenia, it's criterion A for more than 6 months. And then in schizophrenic disorder, you'd have criterion A plus a major mood disorder. But within a 2-week duration, the psychotic features are present without mood symptoms at all. And that's usually for a duration of more than 1 month. In the case of delusional disorder, you usually have non-bizarre delusions as well as hallucinations for more than 1 month. So I'm not going to go through the whole DSM-5 criteria due to time constraints. So I'm going to jump straight into the management of psychotic disorders. So in general, psychotic disorders are managed using the biopsychosocial approach. You can split it into acute management, intermediate management, as well as chronic management. So in an acute setting, it's important to establish whether a patient is presenting in the index episode or if they're a known mental health care user. So in the case where it's an index presentation, you want to manage aggression as previously discussed by the previous group. It's important to rule out underlying medical conditions, as previously mentioned, as well as to rule out substance abuse by taking your urine sample. At this stage, you can start on a low dose of a first-generation antipsychotic, which I'll cover in the next slide. But because it's an index presentation, all cases actually require referral to a facility where a psychiatrist is available. So we found in district hospitals such as Begum Langeni, a psychiatrist is generally available. In the intermediate side, it's usually what happens in the ward. So because we're not really that involved at this stage of the management, I'm not going to go too much into depth with it, but in general, you want to involve the social worker for assessment of family dynamics, support, try to gain collateral if it's not present, monitoring of side effects of the antipsychotics that you started, monitoring response, which should technically be done at a 4 to 6 weekly interval. Supportive counseling can also be done once the patient has resolved in psychosis, just to assist with insights. Occupational therapists can also be involved just to help with functional assessment. I'm going to cover the chronic aspect afterwards, but I just want to go more into if somebody is a known mental health care user. So again, in the acute phase, you just want to manage aggression. But in patients such as these, you want to continue on whatever antipsychotics they were on previously. But you refer if they have poor insights, poor support, if they are high risk to themselves, others, or property, if they're pregnant or lactating, if there's no response or an intolerance to the medication, or if they have a concurrent medical or psychiatric illness. And essentially the intermediate phase, again, it's when they're in the ward. It's what you want to do is establish the reason for relapse. So look into adherence, or also take into account maybe it could be a non-response to the antipsychotics. So this is a situation where they're adherent to their medication, but they're still not responding. At this stage, if the patient has no response, you could consider perhaps switching the drug. If there is a response, you could then consider just titrating up the dose. In the case where a patient has non-adherence completely, you might want to consider using long-acting preparations, which I'll also go through. In the chronic phase, so this is like monthly to 6 monthly visits, this is more at a local clinic level. You want to continue rehabilitation. So continue with the occupational therapist's interventions, such as functional assessment, assisting them with coping with their job, integrating them into society. Also social workers, so in terms of finding placements, assisting with social grants. It's also important at every single visit that you assess the patient's risk to self, others, property, as well as a risk to relapse. It's also important to provide psychoeducation to both the family and the patient, and to also provide adherence counseling. Annually, it's important to check, do a metabolic screen. So that includes a BP, HGT, check UNEs, a BMI as well as doing a lipogram. So I just want to briefly go into antipsychotics. So antipsychotics generally work by blocking to varying degrees dopamine activities in target brain pathways. So you have two types. You have a typical as well as atypical, both of which actually have the same efficacy except for clozapine, which is used in patients who have refractory cases. So in general, there's no advantage in combining antipsychotics. So what we generally do is we usually, when a patient comes in, we generally start them on an atypical antipsychotic. Commonly, we start off with risperidone, and there's also clozapine or olanzapine as well as quetiapine. But the side effects that commonly these antipsychotics share is metabolic syndrome. They also have a mood stabilizing ability as well, because of the ability to block serotonin receptors. They also have a less chance of causing extrapyramidal side effects. So typical antipsychotics commonly used are haloperidol. They unfortunately cause extrapyramidal side effects, and they generally don't have good mood stabilizing abilities. So I just want to go into extrapyramidal side effects just briefly. I'm seeing the time. So with extrapyramidal side effects, your risk groups include males, those with underlying medical conditions such as epilepsy, those who are antipsychotic naive, those who you've started with a typical antipsychotics. So you get acute dystonia, which is generally sustained muscle contraction, pseudo-Parkinsonism, which is as per Parkinson's disease. You can also get akathisia, which is a more subjective motor restlessness, as well as tardive dyskinesia, which is a more choreoarthrotoid involuntary movement, which is more late appearing. General management, you'd want to stop the antipsychotic, decrease the dose, or consider switching to an atypical antipsychotic. In general, we manage them using anticholinergics. What's available is bipyridine, except for tardive dyskinesia, which may actually exacerbate. In that case, you use benzodiazepine and beta blockers. Prophylactically, you can actually give the patients ofenadrine, about 50 to 100 milligrams per hour, 6 to 8 hourly, but it's generally not given all the time. It's only given when you suspect that the person has a high risk of developing extrapyramidal side effects. So in general, we refer cases to a psychiatric doctor just for them to review the antipsychotic medication. So if a psychiatric doctor is available at your facility, you would just consult them. And then lastly, just in terms of antipsychotics as well, there is a condition known as neuroleptic malignant syndrome, which is rare, but it is potentially life-threatening. It's due to quite a severe blockade in the dopamine receptors. So in general, these patients will develop an altered mental state first, followed by hypothermia, autonomic dysregulation, as well as muscle rigidity. At your risk groups are usually your young patients, those who are antipsychotic naive, those who are on high dose of antipsychotics or on a typical antipsychotics, or who are given antipsychotics using the intramuscular or intravenous route. In a case of polypharmacy, if they have multiple comorbidities, dehydration, is a previous episode of neuroleptic malignant syndrome, or family history. In terms of the investigations, it's important to rule out other differential diagnosis, other causes for the symptoms that they present with. But more specifically, you could take bloods, CK, which is usually elevated 4 times the normal value, or pull out an ABG, which would generally show metabolic acidosis. In terms of the management, generally, you want to stop the antipsychotic, you want to symptomatically treat the patient. So cool the patient, give them IV hydration, oxygenate them as well, because they generally have respiratory depression or failure. There are pharmacological interventions that can be taken. So you could give bromocriptine, generally use a dose of 2.5 milligrams per os, 8 hourly. You can also give dantrolene if it is available in IV form. Generally, the dose is about 50 to 75 milligrams, or you can consider using benzodiazepine. It's very important that all these patients are referred, because it is a potentially life-threatening condition that does require a high care admission. And then I'm just going to end off to here, and then
Okay, so I'm going to be discussing mood disorders. So a brief overview is that when there's a general emotional state or mood is distorted, and this interferes with their day-to-day ability to function. So according to DCM-5, mood disorders have been broadly categorized as bipolar disorders and depressive disorders. So bipolar disorder is further categorized as the mentioned. I just won't go over it because of time. And a depressive disorder, the same. They're further categorized into the ones that I wrote below. I won't specify because of time anymore. So major depressive disorder is characterized by depressed mood, accompanied by loss of interest and decreased experience of pleasure and social withdrawal. Irritability may also occur, especially this is noted in adolescents or school children. There might be a reduction in sleep, appetite, energy, motivation, concentration, and memory may occur. The patient may report feelings of worthlessness and hopelessness and express thoughts of suicide. Symptoms are usually present for at least 2 weeks, and it impacts on the person's ability to function normally. And as my colleagues have mentioned, it's very important that you exclude underlying medical conditions that may be causing the patient to have depression, example, thyroid disease. So I also divided just an overview of how we manage them, but my colleagues have explained a lot of it. So biologically, antidepressants are the primary mainstay of treatment, and usually the first line is selective serotonin reuptake inhibitors, example fluoxetine orally. So you initiate the patient on 20 milligram, and then you titrate up as the patient is not responding. So within 4 to 8 weeks after you've monitored the patient. You might also give citalopram. Initially, also the dosing is from 20 milligrams, also going up as the patient, as you see the patient and as you monitor the patient over time. Psychological, as my colleagues have mentioned, individual therapy for these patients are very important. Family therapy and group therapy are also very important for these patients so that they can deal with the whole depressive mood. Socially as well, you offer rehab and you offer social skills training. When do we refer these patients? If they have inadequate response to treatment, if you suspect that the patient is highly suicidal or the patient actually has psychotic features. So as mentioned, when would you refer the patient is when if you're worried about suicide or if you have a high index of suicide suspicion. So the suicide risk assessment is a really quick one that we can just quickly go over, and the mnemonic is sad persons. So you can just do this, and then according to the score that you get, you will then decide whether the patient needs can be treated at the primary healthcare level, or do you need to escalate the patient, and how would that be? So all patients who have attempted a medical serious act of self-harm or suicide, you need to refer. All patients who have imminent risk of self-harm or suicide, you refer. If they're high index of suspicion, and patients who are medically unstable, you would refer. You'd refer such patients. And another major group to discuss is bipolar disorder. So bipolar disorder may have an episodic or variable cause. The patient may present with mania, hypomania, or depression. By definition, a diagnosis of bipolar requires either a current or previous episode of mania or hypomania and a past or current major depressive episode. An episode of mania is typically characterized by an elevated mood, increased energy, goal-directed activity. They're talkative, they have flights of thoughts, reduction in need for sleep, and grandiose or religious delusions. Even during periods of relative euthymia, without either clearly manic or depressive features, patient may still experience impairments in psychosocial functioning. An overview of their treatment: the mainstay of treatment for these patients is lithium, also starting at 250 12 hourly, and you obviously up titrate from about 200 to 500 milligrams per dose 12 hourly as well. And it's very important that you monitor these patients very closely, because they have a very narrow therapeutic index. So it's very important that you follow up and monitor them. And it's very important for these patients who will be put on lithium to monitor their renal function. Another thing that you might put the patient on is valproate, which is started at 300 milligrams 12 hourly, and also the doses can be up titrated. So the most important thing about these bipolar patients is that it must be treated with caution, as the patient might switch from depression to mania, and monotherapy with antidepressants should be avoided at all costs. So I won't go into the physiological, social treatment, because it's the same as my colleagues have mentioned and as I have mentioned before. When do we refer these patients? Is that if they have mixed features of rapid recycling bipolar disorder and depressive episodes in bipolar patients not responding to second-line treatment, and patients with manic episodes not responding to treatment, or mania with severe psychotic features. So common side effects with the most, so I'm not going to go through all of them, but a very important one with SSRIs is what you call serotonin syndrome, because this is life-threatening and it is considered as an emergency. So the patients will have symptoms happening within minutes to hours, and may include agitation or restlessness, diarrhea, fast heartbeat and high blood pressure, hallucination, increased body temperatures, loss of coordination, nausea, overactive reflexes, rapid changes in blood pressures, and vomiting. So we also treat them with benzos, and then you refer the patient to a tertiary institution to be monitored, as primary health care obviously doesn't have such facilities to monitor the patient. Yeah. So in summary, just to close off, I think the aim of this is to make sure that we understand that we need continued education of ourselves and our patients to ensure continuity of care and good help-seeking behavior. It's important that we also understand the processes of referral and treatment, which I hope we've made a little bit clearer, that are relevant at each level of care, and to ensure that our communities receive the best care from us. And like I said, to destigmatize mental health care with the awareness of our cultural context, to ensure good adherence, help-seeking behavior, and in general, good mental health. Thank you.
Okay, thank you very much. I think in closing, we've gone a little over time, but in closing, there's some important points to make. I'm just going to ask for people to do another poll. So let me just go through it. If you can just put in that poll, give your assessment to the presenters what you thought of the presentation. In the meanwhile, I want to urge all of you, whenever you're presenting, to please reference all that you are talking to. And I think it would be important, you can put the full reference at the end, but please in your slides indicate where that reference, where you are quoting certain things, where they're coming from. If you can put it on each slide at the bottom in small, it's also useful. It can help us talk to and understand and talk to the evidence and the way in which you're using it. So please be aware of that. I think there were 1 or 2 questions. I think one was about the MH4 and 5 forms. I think you need to, the MHCA forms, you need to just see the context and then respond to it. It doesn't have any specific guideline, but the idea is to make sure that you are fulfilling the requirements as per the Act in the time sequence as you are keeping them for 72 hours. I think other than that, just a mention about SNRIs. This is a newer set of drugs that are much more stimulant. But what I would also like you to think about carefully, which is why I wanted to understand your referencing, is to see anxiety, anxiety as part of the spectrum of depression as a mood disorder, and that there's often a strong overlap between them, also with manic states. So you should see that as one kind of condition which can vary in the manifestation. So yes, some people may become manic, but the underlying problem is depression, anxiety. And if you're seeing how it is being managed nowadays, it's seen as a spectrum of sorts. So please keep that in mind. I think, thank you all. This is intended to be just a taster for you to get a sense of some of the issues. You cannot possibly manage all of mental health care in a short half hour. So thank you very much for the good attempt. And as I say, please in future do indicate your references so that we can be a little bit more engaged. I have shared on the chat group some references. Please look at them as well. They're kind of useful. Okay, everyone, take care. Bye-bye, and have a good weekend. See you next week.